Welcome to the CMEssentials audiocast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello, and welcome to the latest installment of Oakstone's CMEessentials in Family Medicine. I'm your host, Dr. Gaby Berger. I'm an internal medicine primary care physician and clinical associate professor of medicine at the University of Washington. I love clinical medicine and enjoy digging into the literature to find clinical practice pearls that help us manage our patients and improve their outcomes. I look forward to spending time with you on today's topic. We are excited to discuss the topic of hormone replacement therapy, or HRT, and updates in the use of these medications to support our female patients. There have been several recent reviews of this topic and increased awareness that physicians are underprescribing HRT for our patients with symptoms of menopause. Our discussion is presented in two parts. In this episode, we will clarify the stages and progression of menopause, discuss treatment, symptom management, and when to stop HRT, and close by covering primary ovarian failure and early natural menopause. In the next episode, we will touch on contraindications, discuss the value of using HRT to prevent future health problems, and non-hormonal treatment approaches. Let's start by outlining the scope of this problem. It's a hugely important topic as it affects more than 50% of our patients in typical outpatient practices. On average, women spend approximately 40% of their lifespan in the postmenopausal stage. Moreover, it is not talked about enough. Patients are embarrassed to raise the topic with physicians, and physicians lack training and understanding of strategies to help mitigate symptoms. This came up just yesterday in my clinic when one of my patients didn't realize that she was suffering from symptoms of menopause that we can treat. Menopause is a uniquely universal experience for most of our female patients, and symptoms can be extremely disruptive to daily life. Our patients deserve the opportunity to explore treatment options with their physician. I am thrilled to be joined today by Dr. Sarah Merriam, a general internist and women's health expert from the University of Pittsburgh. Dr. Merriam will share her expertise about the management of menopause, specifically the role of hormone replacement therapy. Dr. Merriam, welcome. Before we dive into management strategies for menopause, can you start by helping us understand the stages of menopause transition and the predominant symptoms that our patients experience?
Sure. Thank you so much for having me. I agree that when we think about menopause, it's really helpful to know a few definitions. So menopause, as we think of it, is defined as the cessation of the menstrual cycle, and it's really a retrospective clinical diagnosis that's made at a point in time 12 months after a person's last menstrual period. And menopause really reflects the loss of ovarian follicular function with resulting decreased estrogen concentration and increased follicle-stimulating hormone concentration. And the average age of natural menopause is a median age of 51. Perimenopause is that transition time then. So the transition between regular ovulatory menstrual cycles moving towards menopause. And importantly, perimenopause can last anywhere from 4 to 8 years before cycles completely stop. And so the onset of perimenopause is variable with an average age of onset around 47. And I really think about perimenopause into kind of two phases, the early and the late transition. During the early transition, that's when cycles become irregular and anovulatory. And a person may come to the clinician talking about change in cycle pattern, bleeding duration, frequency, etc. Then during the late menopausal transition, closer to the time of menopause, there can be longer intervals of amenorrhea, and that's generally when vasomotor symptoms begin. I think it's really important to just stop here and say that though bleeding patterns may change during perimenopause, a really important clinical point is that there are intermittent ovulatory cycles, and so a person does remain at risk for pregnancy. And then, as we say, eventually we get to that postmenopause, which again is that 12 months of an absence of menstrual cycles. And I think it's really important also to say that the timing, the prevalence, and the severity of these symptoms of menopause vary really markedly between individuals, and the degree of functional impact also varies between individuals. As I mentioned, vasomotor symptoms, which are generally what we think about when we think about menopause, the hot flashes and the night sweats, begin during the perimenopause. The median duration of vasomotor symptoms are around 7 years, and as many as 10% of individuals will have persistent vasomotor symptoms up to a decade after the final menstrual period. The other very common set of symptoms associated with menopause is now termed the genitourinary syndrome of menopause. And that really refers to a constellation of changes to the labia, vagina, clitoris, urethra, and bladder, resulting from declining estrogen levels and blood flow. And symptoms may include vaginal dryness, pain with sex, vulvar or vaginal spotting, irritation, and even vaginal discharge. And this is really common. About half of women in the postmenopause do carry some degree of these symptoms. We think generally about vasomotor symptoms of being most prevalent early and around the time of the menopause, with increasing prevalence of genitourinary syndrome of menopause later in the menopause transition. And there are certainly other symptoms that are reported, things like sleep disturbances and mood changes and irritability and anxiety, or cognitive disturbances like forgetfulness and sexual dysfunction, to name a few.
That is such a helpful review. I really appreciate that. You know, one of the things that you really reminded me of in the ACP talk that you gave at the national conference early this year was that lab evaluation is really not necessary for most patients over the age of 45 with typical symptoms of menopause. But I'm curious, are there symptoms in which you do recommend confirmatory testing?
Yeah, I think this is a great question. So I agree that in women who are over age 45, a diagnosis of the menopausal transition can really be made if there's menstrual cycle irregularity with or without symptoms of menopause. And so again, in that situation, lab evaluation might not be necessary. But that said, I often will check a urine pregnancy test if there's any change in bleeding pattern. And I also check a thyroid stimulated and hormone level, given the really high prevalence of thyroid dysfunction in this age group. So that's great, but there are other scenarios, which are not uncommon, in which we may consider lab evaluation. And so this may be in someone who is not having typical symptoms of menopause, or in folks in whom the clinical diagnosis of 12 months of amenorrhea really can't be applied. So for example, in people who have underlying menstrual disorders, who are currently using a contraceptive agent, such as a combined oral contraceptive pill, or an IUD, which leads to amenorrhea, right? A person who has a hysterectomy or a history of endometrial ablation. So in those situations, measuring an FSH level can really help confirm menopause and differentiate it from other conditions. And so an elevated FSH level greater than 25 or 30 is really objective evidence of menopause. But I want to throw a flag of caution here. Though FSH levels do gradually increase throughout the menopause transition, during that 4 to 7 years of perimenopause, when a person is having interval cycles, FSH levels can be through the roof one day and then in the basement the next. So they're really unreliable during that time. I also think about using FSH levels, again, as mentioned, in people who are using contraceptives. So for example, if a person is using an IUD, that's fine. But in a person who's prescribed exogenous hormones like hormonal contraceptives, again, that will impact FSH measurement. And so really that hormonal contraceptive agent needs to be stopped and then an FSH level measured 2 to 4 weeks later. And again, if you're going to try to use an FSH to make a diagnosis of menopause for whatever the situation and you're stopping a contraceptive agent, you do have to remember to protect that person or give good anticipatory guidance about pregnancy prevention if that's that person's goal.
Fantastic. Those are great clinical pearls about the FSH in particular and its utility when we can really think about relying on that in the clinical setting. I'd love to actually transition now and share a case with you of a patient of mine and get your perspective on her care. So Carrie is a 53-year-old female with a history of sciatica, mild depression and anxiety, and hypothyroidism, who presented to my primary care clinic with new hot flashes for the last 3 months and irregular periods for the last 6 months. These hot flashes occur most nights of the week. She's waking up, let's say 2 to 3 times overnight to change her shirt. She started sleeping on towels so she doesn't soak through the sheets and disturb her bed partner overnight, which has definitely been an issue for her. The hot flashes also bother her during the day, where she works as an office manager for a large nonprofit and has been dressing in layers to avoid sort of embarrassing sweats during meetings. She is more tired than usual, which she has attributed to disrupted sleep. She doesn't have any other systemic symptoms like fever or weight loss. She does note that she's more irritable with her partner and kids recently. She has been on sertraline for the last 10 years for mood and anxiety, which has worked really well for her. However, now she's feeling really easily frustrated. She's struggling with a lack of focus at work and at home, which she's calling, quote, brain fog. She hasn't heard from any coworkers about concerns that she's dropping the ball at work, but her partner has mentioned that she seems more on edge recently. She continues to have periods, but notes that they are no longer regular and seem much heavier than usual, which is super frustrating for her, as it's hard to predict when she might start bleeding and for how long. So I did order a TSH, just as you had suggested, and a CBC with DIF, both of which were normal. I realize that was a lot of information, but I'm curious to hear how you might approach treatment for this patient.
Yeah, so this is a very classic presentation of a person who's entering the perimenopause. And I think what this case really highlights is how incredibly functionally impairing some of these symptoms can be to our patients. And I would say that in my experience, a lot of times people kind of view these symptoms as their cross to bear, and they don't realize that there are really effective treatments that we have to offer to manage these. And so I'm so happy that your patient reached out to you in clinic. I think that's great. I hope we see more of that with increasing kind of spotlight on menopause in the popular media. But I also think it's really important for us to surveil for some of these symptoms in appropriately aged patients in our practice. To your point about how I would manage this patient. So when I'm thinking about the perimenopausal person who is having some constellation of irregular bleeding or vasomotor symptoms that are bothersome, the thing that I reach for first, assuming there are no contraindications, are really combined oral contraceptives. They are great. They both provide contraceptive benefit. They also regulate bleeding, and the estrogen therein also treats the vasomotor symptoms. So that's really what I reach to as a first line. And my approach is to start them and then continue them until, again, the average age of menopause around 51 or 52, and then stop and see what happens with bleeding pattern. If a woman continues to have irregular bleeding, it's reasonable to extend the COC use. But if she's amenorrheic, she's likely entered the menopause, and then combined oral contraceptive agents can be stopped. Once you have the period of time where you're fairly confident that you are now past the final menstrual period and in menopause, that's when I really reach for hormone therapy. And again, that's the most effective treatment that we have to offer for menopausal symptoms. Some studies quote 70 to even 90% improvement in frequency and severity of vasomotor symptoms within just a few weeks. We don't have very many treatments that are that effective. And then the goal of hormone therapy is really just to replace the hormones that a person's body stops making during the menopause. So hormone therapy is comprised of either one or two agents. So in a woman with a uterus, hormone therapy is comprised of estrogen, the active ingredient, which is treating the vasomotor symptoms, the vaginal symptoms, and then progesterone, which is added to protect the endometrium and really prevent against endometrial hyperplasia and cancer. And then for women who don't have a uterus, then progesterone isn't required and you just use estrogen only hormone therapy. And I think this is a really important clinical distinction because the risks conferred by these different regimens are also variable, and we can talk about that later. But again, both estrogen and progesterone can be prescribed in different formulations. So estrogen, oral, transdermal, vaginal, all of those preparations are equally effective in treating symptoms. But I tend to reach for transdermal formulations first if a patient is open to that, because we know that oral estrogen actually has a greater impact on the liver with a first pass effect. So you get higher portal vein estrogen concentrations, and that actually leads to a higher risk of VTE and stroke than with transdermal estrogen. And so again, that is my preferred agent taking into account patient preference. And then progesterone, if needed, can be, again, prescribed in oral formulations in a transdermal patch. And then also levonorgestrel containing IUDs can be combined with estrogen formulations to give endometrial protection that isn't FDA approved. So off-label use, but also really handy for patients who have an IUD or are interested in having an IUD.
That is super helpful. And I'm so glad that you touched on this distinction between oral estrogen versus transdermal. One of the things that I found actually, as I inherited some patients on my panel from colleagues, is that many of my patients who are on hormone replacement therapy tend to be on oral estrogen rather than transdermal. I have begun to make this switch when I'm initiating HRT to start with transdermal estrogen. But one thing I'm wondering about is whether I should be transitioning folks on oral estrogen to a transdermal formulation. And maybe a follow-up question to that is there a time then that you would prefer oral estrogen to transdermal?
Yeah, I think these are great questions. So, again, all things being equal, yes, if a person is open to transitioning from oral estrogen to an estrogen transdermal formulation, then that's great. And I typically, when I'm inheriting patients who are already prescribed hormone therapy, I will have that shared discussion with them. But I would say for hormone therapy, just like any medication, it is going to be most effective if the patient is using it. And we have to take into account also personal preference. We've all had patients who use nicotine replacement therapy, right? And they can't really tolerate the nicotine patch and they really prefer other options. And I think about this the same. So I offer it, I have a discussion, but I don't necessarily push really hard if a person's doing well on a particular formulation just to make the swap. I do want to make sure that they're informed of all of the data that I have to offer them. And then in terms of, is there a time when oral estrogen is really preferred? Not to my knowledge. I think most of the data one is not going to be more effective than the other. And so again, I don't reach for oral estrogen unless I think of it as being preferred because that's the option that the patient will take and use with consistency.
You did a great job of really helping us begin to understand how to manage the symptoms of menopause. And I guess I want to just take a step back for a moment and acknowledge that as a PCP, I really feel as if HRT has fallen out of favor among primary care providers in the US. I'd love to hear your perspective on why this is.
Yeah, I think there have been ups and downs over time in our understanding of risks and benefits of hormone therapy. And there have been ups and downs in our messaging of that to patients. And all of this has kind of led to mass confusion. Looking kind of across the timeline, when hormone therapy was initially marketed, it was really promoted as this formulation that was going to be kind of like a fountain of youth, and it was going to treat a multitude of illnesses and keep people young and beautiful and sexy and healthy. And at that time, estrogen was prescribed as a single agent. And then, of course, about a decade later, we have initial trial data showing that unopposed estrogen is linked to endometrial cancer, and the use of hormone therapy then dropped a bit. Then we had additional discovery that adding a progestin really reduces the incidence of endometrial cancer and protects the uterus. So now we have hormone therapy back on the upswing, and it increased even further into the 1980s when hormone therapy was found to prevent osteoporosis, and then even further with the Nurses' Health Study and some other data that showed that potentially estrogen is going to be cardioprotective. And then comes the Women's Health Initiative, which is the data we're all very familiar with, published in 2002. And just as a brief reminder, that was a randomized prospective double-blind trial of approximately 27,000 women between 50 and 79 that was really designed to examine the balance of risks and benefits of postmenopausal hormone therapy in healthy women. And in that study, it was terminated after about 5 years due to these big safety concerns when preliminary results indicated increased risks of cardiovascular disease, stroke, venous thromboembolism, and breast cancer among women who used hormones compared to placebo. There are definitely some challenges to interpreting that data. The average age of entry into the study was 63. Women with really severe vasomotor symptoms were excluded. And then a large portion of women in both treatment and placebo arms had prior exposure to hormone therapy. And so again, this is probably the best data that we're ever going to have. And it's certainly better than smaller observational data that we do. But we really have to look at subgroup analysis of this data to understand better the risks and benefits of hormone therapy.
Great. Thank you so much for that overview, and particularly the information about the WHI study, which again, I think is the one that we all anchor to in terms of thinking about how to prescribe hormone therapy and how to do it safely. One thing I'm really curious about is this new FDA-approved medication for genitourinary symptoms, ospemifene. I have not used this at all in my practice, and I'm curious to hear from your perspective if and how you've used it for your patients.
To be honest, I'm not using a lot of ospemifene either in my practice, but it is an oral selective estrogen receptor modulator. It does not have clinically significant estrogenic effect at either the endometrium or the breast, but it is FDA approved for the treatment of moderate to severe genitourinary syndrome of menopause symptoms in postmenopausal women. We don't really have any studies to date that directly compare this treatment with vaginal estrogen therapy. I typically recommend it if a person is unresponsive to non-hormonal treatments, so vaginal moisturizers and lubricants, and or in folks who cannot use a vaginal estrogen product or prefer not to use a vaginal product at all. The big side effects of ospemifene, which limit its use, are increasing hot flash burden, which in menopausal women can really be tough. And also there is a slightly increased risk of venous thromboembolism.
I'm also curious if you've ever used vaginal prasterone or DHEA for genitourinary symptoms. Again, it's not something that I've incorporated into my practice, but I have read about this therapy in papers and in the literature. And I'm just curious if anyone's using it and if there's any advantage to this over vaginal estrogen.
I have actually had some patients coming and asking me about this too. So I think this is an important topic. So vaginal DHEA is approved by the FDA. There's a daily vaginal suppository for the treatment of dyspareunia in the setting of vaginal atrophy or vulvar atrophy related to menopause. It is effective, but I would say relatively less studied than vaginal estrogen. And based on the data we do have, it doesn't appear to be more effective than vaginal estrogen. And again, we have more collective data and clinical experience with vaginal estrogen. So I tend to use that more for genitourinary syndrome of menopause when I'm able. And then further, DHEA, again, requires a daily dose, whereas vaginal estrogen is generally about twice a week. So I find that from that perspective, it is also a barrier to increase uptake. I think it's getting a little bit of attention and press now because there is some off-label use for this medication for libido. And it does slightly increase circulating testosterone levels, although I will say that there's even less data for this indication. And I would say that vaginal DHEA is thought less likely to have significant impact on libido. But I do see people asking me about it in my practice. But again, like ospemifene, not something that I'm using a lot of at this time.
That's really interesting and helpful. I've had just a couple of patients asking me about the vaginal DHEA and referencing the libido aspect of it. And I really had not had that clinical context previously. So I appreciate your perspective. Before we let you go, Dr. Merriam, I'm wondering if you can provide any guidance about how or when to stop hormone replacement therapy.
Sure. I think when we think about hormone therapy, as a general rule, the benefits are going to be greatest, and they're going to generally outweigh the risks for healthy people who have moderate to severe vasomotor symptoms and for whom are within about a decade of menopause or less than 60 years of age. Certainly, we know that the risks increase as age increases and as duration of use increases. And, when we look at the most recent NAMS statement from 2022, they are really supportive of the shared decision-making moment. They say in that guideline, because many women will experience bothersome vasomotor symptoms for many years, long-duration hormone therapy may be needed, and an arbitrary age-based stopping rule is not clinically appropriate. That said, in folks who are treated with estrogen alone, because the risks are much less, and we're really become clinically significant when we think about the risk of stroke or VTE around 10 years of use, that's when I usually start to broach it in my clinical practice. For people who are prescribed estrogen and progesterone, the clinical significance of breast cancer really manifests earlier than that, around 5 years of use. And I make a good-hearted effort to take patients off of combination hormone therapy at that time, or at least do a trial and see how things go. Certainly, if symptoms recur, you can lower the dose of estrogen, or think about transdermal options, or think about some of the non-hormonal options that I think you're going to be talking about in the next episode. And there are some new ones on the block too coming soon. So hopefully we'll have some other options to reach for. And so that's generally what I think when I think about systemic hormone therapy. And again, when we're talking about local vaginal estrogen therapy for genitourinary syndrome of menopause, really don't have a stop date for that one. And I use it liberally in patients who are having symptoms.
I can attest to how helpful treatment for the genitourinary symptoms in particular is for my patients into their 70s and 80s. And I think it's so important for us to recognize that people at that age still want to have libido and sex, and treating those symptoms is incredibly patient-centered and important. Before we let you go, I do have one last question. And that is how you approach the treatment of patients who experience primary ovarian failure or early natural menopause. And I realize this affects a smaller percentage of our overall patient population, but I do think it's important to at least acknowledge that not everybody is on the same timeline.
Totally. And we know that really early estrogen deprivation, either from early natural menopause, as you mentioned, from ovarian failure, as you mentioned, or from surgical menopause, is associated with a number of long-term adverse health outcomes. And while we don't have this large prospective RCT data available to guide our practice, we do have an abundance of observational data that really show an increased risk of coronary heart disease, of osteoporosis, of other metabolic and mental health conditions. And again, based on observational data only, we have some evidence that using menopause hormone therapy mitigates some of these outcomes. So I practice in accordance with NAM's guidance, and I initiate menopause hormone therapy in women with surgical menopause before age 45, or one of the other conditions you referenced, even in the absence of typical menopausal symptoms. And then I continue that hormone therapy until the average age of menopause, 51, 52. We lack really high quality data to support an ideal dose or duration, but there's a really wonderful article by Konitz et al. Published in JAMA in 2021 that provides some great recommendations for standard dose formulations, and actually makes mention that in those who are having high burden of symptoms, who are younger, they may even need higher than standard dose hormone therapy regimens, again, to prevent some of the bone and cardiac outcomes. So I would reference you to that article. It's been really helpful to me in my practice.
Thank you so much for your time. We're going to close this episode by summarizing the key take-home points from Dr. Merriam and from the literature. Hormone replacement therapy is the most effective treatment for vasomotor symptoms of menopause and should be considered for patients under the age of 60 and within 10 years of menopause. Transdermal estrogens appear to have a lower risk of thromboembolism and stroke than oral estrogens. Local vaginal hormone therapies are the preferred treatment for patients with isolated genitourinary symptoms. Patients who experience early menopause should receive hormone therapy at least until the average age of natural menopause.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CME Essentials in Internal and Family Medicine. To learn more, visit oakstone.com.